So some disclaimers: the views expressed in this presentation are those of the speakers and don't necessarily represent the official position of NIOSH or CDC. Mention of any trade names, commercial practices, or organizations does not imply CDC NIOSH endorsement. And finally, citations to websites external to CDC NIOSH do not constitute endorsement by those agencies. Furthermore, NIOSH CDC is not responsible for the content of those websites. And for disclosure, CDC, our planners and presenters wish to disclose that they have no financial relationships, with one exception, Dr. Delahose. He attended promotional programs hosted by AstraZeneca, GlaxoSmithKline, and also received a lecture honorarium. And these items have been mitigated. So without further ado, I'm now going to hand over the lectern to our esteemed Dr. Udison.
Okay, so we turned from blue to red, and I want to say that this is actually scarlet because we here in New Jersey of the Scarlet Knights began to think about sleep apnea and exposure to world trade. And I'm going to tell you how we got started. I am the clinical center director here, and I found I was sending an awful lot of my patients to Dr. Sunrum that were at World Trade. And so we got heavily involved in the Association of World Trade Center and sleep apnea. So next slide. The goals in this talk, I want to show you the early studies and where we got the idea that world trade was associated with sleep apnea, and it was through seeing the excess of aerodigestive diseases, including rhinosinusitis and gastroesophageal reflux. We're going to be discussing some of the studies about World Trade Center responders and this association with chronic rhinosinusitis, which are going to be mechanistic studies. My colleague, Dr. Sunrum, is our sleep apnea expert, and he's going to be summarizing the diagnostic and treatment best practices, which were also published in our environmental perspective series. And these are endorsed by American Academy of Sleep Medicine and the Department of Veterans Affairs. And finally, we're going to be doing some case studies because the idea in my mind is for which kinds of things we need the sleep experts and which kinds of things that we in primary care can do ourselves. So next slide. On the day of 9/11, Rutgers sent a delegation, including Dr. Pouliot, in the early onset of 9/11, and you can see the large cloud of dust particles that took place that day. So we knew that there were certainly a lot of problems, upper and lower airway injury. And Dr. Leoy, who's no longer with us, is the particle expert. Next slide. And what were the people exposed to? What was so bad? And probably the worst thing of all was the ground up cement dust. We worry about asbestos, of course, but the ground up cement dust is the material that had a very high alkaline pH and was responsible for many of the problems we see at World Trade. Additionally, the volatile organics, polyaromatic hydrocarbons, charred wood, and just overwhelmingly 100,000 parts per million of particles. 100,000 parts per million, that's an awful lot of particles. Next slide. So the first slides that we did, the first studies that we did were back in 2006. And who did we study in the original studies? This is the general responder program, so this didn't include the New York City Fire Department in these assessments, but you can see almost 30% of the original people were law enforcement, 34% constructions, communications were high, and law enforcement might have been even higher than this, but this was the original group of people that we studied, the first 9,400 people that came in. And next slide. And we found that even at the time of their exams, which were already for many people already 5 years after the exposure, then almost 70% of the people had some respiratory issues, mainly upper respiratory, an awful lot of lower, but 63% upper respiratory. More than half were symptomatic at these exams, and we were able to correlate early arrival with exposure. Next slide. And our friends in the New York City Fire Department, so remember the previous slide was not firefighters, so even in the first group of firefighters, somewhere 17% of people without an obvious risk for obstructive sleep apnea qualified as having sleep apnea, and again, GERD and sinusitis were extremely common in these people. Next slide. So what have we been seeing in the program? And you can see this is a summary slide that maybe is going to come up in others of these talks, but you can see that sleep apnea, which is highlighted, is the 5th most common condition that we're seeing now. Note a lot of comorbid conditions, comorbid asthma, comorbid respiratory issues, cancers, post-traumatic stress disorder, other mental health disorders. So you can see that sleep apnea, while it's not the only thing we see, is very common. Again, 5th most common, and something that we're concerned about. So the next slide is going to be where I'm going to turn over to my colleague. But what we noticed, the clinicians here noticed, which was primarily Dr. Maricoli and myself, that our patients were snoring a lot, and they weren't very heavy. They didn't look like the classic patient that had sleep apnea. They were maybe a little bit higher body mass index. And so I got my colleague, Dr. Sunrum, really interested in sleep apnea and World Trade Center responders. So this is where I'm going to turn it over to him, because this study was our combined study, and we're going to go from there.
Thank you, Iris. So thanks for that nice introduction. What was very interesting to us when we began these studies in 2011, which have been ongoing since then and has led to an incredible collaboration between the clinical centers of excellence and our division, has been this ongoing question of sleep apnea in this population and the association with aerodigestive disorders, including chronic rhinosinusitis. The first studies, as Iris mentioned, was a small study looking at, comparing a population that was being sent to the sleep center on a routine basis and comparing them to the World Trade Center responder population, who almost all of them had these aerodigestive disorders, but also had snoring and daytime symptoms and complaints of sleep disturbance. And the idea was to see what was the reason they were having these issues, and could we come up with some kind of hypothesis as to the mechanism of their sleep apnea. And we hypothesized that maybe the upper airway inflammation that was because of those exposures led to sleep apnea and these aerodigestive disorders, and that it was therefore a unique characteristic in these patients for the mechanism of sleep apnea. Next slide, please. And so what we did was just a cross-sectional comparative study between these populations, 50 with these symptoms from the World Trade Center population and 50 who were regular sleep referrals, who were between the age of 30 and 60. And what was clear was that while in the control population, there was a strong correlation between BMI and their apnea-hypopnea index, there was no such correlation between either BMI or weight or the apnea-hypopnea index. And I will describe what we mean by the apnea-hypopnea index in a bit in the responder population. Responders who had this new onset of symptoms of snoring had a significantly lower BMI than those than the previous habitual snorer. So within that responder population itself, we found two categories: those who probably had sleep apnea even at prior to 9/11, and then a new set of responders who began to have symptoms and sleep apnea that was really probably exposure related. So what we concluded was that it was likely that there were mechanisms other than obesity that may be important in the pathogenesis of sleep apnea in this population with aerodigestive disorders. Next slide, please. So this brings me to, trying to explain what we mean by OSA. What is the definition? How do we classify severity? How do we diagnose the problem? And go back to looking at mechanistically, why is it that the World Trade Center population may be at increased risk for this disorder? So as everybody may or may not know, what we know is that when you have an obstructive event, there is a blockage of the air passages in the upper airway that doesn't allow air to move in, despite an increasing effort on the part of the person to try to get that air in. That increasing effort, in fact, could potentially make the obstruction worse, leading to these events of asphyxiation, essentially progressive asphyxiation, which has consequences as a result of that. There are lots of anatomical, mechanical, and sleep factors that lead to this airway obstruction, because while a person may be obese, they do not have sleep apnea unless they sleep. So there is that factor of sleep that is important. In addition, there are certain anatomical features and mechanical features that are important to understand that may have nothing to do with the body habitus. Next slide, please. So we're going to define a few terms. We did talk about something called the apnea-hypopnea index. And what we mean by that is there are events of apneas and hypopneas. So what are apneas? It's this complete cessation or at least a 90% reduction in airflow. Please go back. Thank you. Of airflow for a minimum of 10 seconds. And this is usually associated with an EEG arousal that may drop the oxygen saturation. It's important to understand that an apnea does not require oxygen desaturation to occur. However, it would be very rare for an apneic event not to be associated with desaturation because you're having a complete cessation of airflow. Next slide, please. All right, so here is a classical description of, or a polysomnograph feature of an apnea. On top are the EOG, the chin EMG, and the reason it's called a polysomnogram is there are multiple leads. You have EEG to tell us if the patient woke up or not. You have EKG leads and then leg leads and then a snoring lead. And then you have the nasal pressure, which is what is shown here, followed by the thermistor tracing, the thoracic and abdominal movements, and in this particular situation, esophageal pressure, which is not often measured, and then oxygen saturation tracing. And what you'll notice here is that the nasal pressure tracing and the thermistor tracing show a complete flattening, showing an absence of airflow despite the thoracic and abdominal movement being still present, although having paradoxical movement. You'll notice that the esophageal pressures are increasing in an effort to try to open up that obstruction, and ultimately the patient wakes up and opens up that airway. Notice, however, that in this particular example, there isn't much of an oxygen desaturation, but this can vary from patient to patient. Can you please go back to the previous slide? Thank you. So now that's an apnea. How about a hypopnea? So hypopneas have been had multiple definitions. The first definition of hypopnea was in 2001 when they formalized exactly what the American Academy of Sleep Medicine formalized exactly what we mean by a hypopnea. It was the Clinical Practice Review Committee that came up with this definition as a 30% or greater reduction in airflow associated with the oxygen hemoglobin desaturation of greater than 4%. Now, this definition was what was ultimately recognized by CMS for reimbursement and remains the definition that CMS uses for reimbursement purposes for hypopneas. In 2007, the American Academy of Sleep Medicine revised their definition of hypopnea and used what they called an alternative hypopnea score, where they based it on the fact that you should have a greater than 50 or more % reduction in airflow, but this may be associated not with a 3%, but with a not with a 4%, but with a 3% decrease in saturation. And not only that, but you may not have a decrease in saturation. As long as you wake up from such an event, it could also be defined as hypopnea. So there were either a 3% decrease in saturation or an arousal, making the definition of hypopnea. And this became formalized in 2012 as the actual main definition of hypopnea. However, like I mentioned, CMS has retained the 4% desaturation definition even to this day. Next slide, please. So here is a hypopnea. And what's different in this hypopnea as compared to the previous, you'll see the EEG, EMG, and eye tracings, EKG, and the microphone for snoring. And the next is the nasal cannula airflow or air pressure, airflow, chest and belly movements. And you'll notice the chest and belly movements, but a reduction in that airflow and a reduction in the nasal cannula pressures, which then ultimately is relieved while the patient is making an increasing effort, associated, as you notice in the EMG tracing, of an increase in tone of the EMG showing an arousal. So here, notice that the saturation hasn't dropped, but the patient wakes up. So this is a hypopnea based on the ASM definition, but not based on the Medicare criteria. Next slide, please. And so how do we diagnose and classify the severity of OSA? If a patient has these events, we count them over the total time a patient is asleep. We call that the apnea-hypopnea index. And if it's less than 5 events an hour, that is considered to be normal. And the severity is just based on the fact that, 5 to 15 is considered mild, 15 to 30 moderate, and more than 30 as severe. Next slide, please. So what are we worried about as a result of these events, which are associated with not only arousals, but desaturation events? Here is a situation of an apnea, which is associated with a significant oxygen desaturation event and an arousal. And what you'll notice is that these two components, the arousal and the desaturation, are what may be the main reasons that we see a lot of both cardiovascular and neurocognitive consequences. Next slide, please. So the cardiometabolic consequences, essentially because you have these episodes of hypoxia with coming back to normal, and so a cycle of deoxygenation and oxygenation termed as chronic intermittent hypoxia. Many studies, both animal and human studies, have shown that the consequences of intermittent hypoxia include daytime hypertension, the risk for coronary artery disease, increased risk for heart failure, new onset of atrial fibrillation, stroke, diabetes, and metabolic syndrome. And so you will notice that a lot of your patients who have sleep apnea have these associated comorbid conditions. And this is because mainly happening because of the association with intermittent hypoxia. Next slide, please. In addition, you have the sleep fragmentation because the patient wakes up repeatedly based on how frequently they have these apneic or hypopneic events, which then disrupts their sleep all night and leads to excessive daytime sleepiness. It leads to reduced attention. And because of this, an increased risk for motor vehicle accidents, impaired mood, impaired quality of life, and cognitive impairment. Next slide, please. So how do we then, so I showed you the classical polysomnograms that had been used in the past to make a diagnosis of obstructive sleep apnea. However, more recently, home sleep testing has become a much more frequently used diagnostic procedure to make a diagnosis of obstructive sleep apnea. And so there have been different classifications or descriptions of type of home sleep tests and regular sleep tests, going from a type 1 to a type 4, where the type 1 is the standard polysomnogram that you see in the sleep lab. This is an attended study, and as I showed you, there are more than 7 signals, including EEG, an electrooculogram, EMG over the chin, ECG, airflow, respiratory effort, oxygen saturations with a pulse ox, and leg EMGs. However, there are more type 2 and type 3 studies that can be used at home, and therefore it is unattended. These tests usually may or may not have EEG channels. They generally usually have a pulse ox to measure oxygen saturations, and at least 2 channels to decide if there's airflow or not, whether they're snoring. Some of these can determine movement and position of the patient. And so there's oftentimes inability to distinguish obstructive from central apneas with these type 3 monitors. And oftentimes we have to determine if sleep based on behavior rather than EEG. Next slide, please. So when do we use these home sleep testing devices? Well, if you have a clinical suspicion of OSA, and if they have symptoms and signs that indicate a risk for moderate to severe OSA, and if they don't have any other significant cardiopulmonary diseases or respiratory muscle weakness or a suspicion for sleep-related hypoventilation or a prior stroke or use of opioid medications or severe insomnia, then you can go ahead and perform a home sleep apnea testing. However, if they have any of these other conditions, then it is preferred that you get a sleep study done in the lab. Next slide, please. Again, a home sleep test doesn't necessarily rule in OSA. Remember that I said we don't have an evaluation oftentimes of sleep. We can't tell if it's central or obstructive. And so if a diagnosis is negative, then we have to see if we have a high clinical suspicion for obstructive sleep apnea and reevaluate that person in a sleep lab. On the other hand, if you have a positive diagnosis, oftentimes that's sufficient to initiate treatment for OSA and follow up after that. Next slide, please. So what's the AASM position statement regarding these home sleep apnea tests? They recommend that only a medical provider can diagnose a medical condition like OSA and primary snoring, and that the appropriateness and the need has to be made based on either a face-to-face exam and history or by telehealth, and that the medical assessment must be ordered by a medical provider, and that it should not be used for general screening of asymptomatic clinical people. And the treatment efficacy and treatment decisions must not be based on just automatically scored devices that would lead to suboptimal care, and that the raw data be reviewed and interpreted by a physician who's sleep boarded. So these are the this is the position statement of the American Academy of Sleep Medicine. Next slide, please. So that comes to, so we diagnose sleep apnea, and what we need to understand is treatment is really now becoming more personalized based on understanding the mechanism that causes OSA in an individual. So an OSA, a patient with OSA has an anatomical predisposition. Now, if he has a stable airway, next slide, he would not have OSA because they have a very stable airway, and no matter what the anatomical predisposition is, they do not obstruct their airway at night. However, they may, on the other hand, have a very highly collapsible upper airway, and therefore they develop sleep apnea very easily. In between these two categories are those who have just a vulnerable upper airway. Next slide, please. Next, please. That then is really, their risk for sleep apnea depends on certain non-anatomical traits. These non-anatomical traits are intrinsic to the individual, and we call them physiological endotypes. These physiological endotypes could be that they have a very poor muscle response to certain negative pressures, such that when negative pressure is generated, if you have a good muscle response, you do not obstruct your airway. However, if you have a poor response, you would. Similarly, if you have a very low arousal threshold, meaning that if you're woken up from some kind of respiratory disturbance and you try to go back to sleep, that actually causes instability of the airway and leads to more obstructive events. And so, in a sense, quick arousals kind of begets more and more obstructive events. And finally, you may have a situation where you have a very unstable central respiratory generator causing you to go in and out of unstable breathing, leading to obstructive sleep apnea. Next, please. And what we know is about half of individuals may have OSA due to these non-anatomical causes, which brings us to our population here in the World Trade Center, where obesity doesn't seem to play a major role. And so it may be that these non-anatomical traits become more important, especially with exposures that may affect muscle responsiveness, may affect arousal or the loop gain in these individuals. And there are ongoing studies that we are performing that is trying to understand the mechanism of OSA in this population. Next slide, please. Next slide, please. So the first study that we performed trying to understand the data from the firefighters from our data showing that those with aerodigestive disorders may have a higher risk for sleep apnea, we were trying to understand what's the relationship between nasal pathology and OSA, and we hypothesized that potentially nasal inflammation leads to chronic rhinosinusitis, and that either predisposes to sleep apnea directly or through an increase in nasal resistance in this population. Next slide, please. And so to do this, what we did was we recruited from 3 different sites at Rutgers, NYU, and at Mount Sinai. We included people who had no snoring or OSA prior to 9/11, were not on OSA treatments, and we did make every effort to recruit current non-smokers as a control population to look at what the prevalence of sleep apnea in this population was. Next slide, please. And what we found was that we were able to recruit about 630 subjects. The average age was what is, the general World Trade Center population age at that time, about 50 years of age. As you'll notice, the BMI was less than 30. Majority were males. And in general, sleep duration was not very long, and only about 40% of the subjects, World Trade Center population, and we're noticing this, is that only 40% have more than 7 hours of sleep or gets more than 7 hours of sleep. Now, Only about half had snoring. Like I said, we had recruited specifically for non-snorers to make sure that we got a good and that there was no selection bias in our study. Again, about 60% actually said they had pretty good quality of life. However, about 40% did not. And very interestingly, the phenotype of this population, which is very interesting to us, is that only 30% of the World Trade Center responder population are sleepy. This is very different from a general medical population that is referred to the sleep center. In those situations, 50% or more of those subjects have, or patients, have sleepiness as their primary symptom. Again, if you look at what other symptoms these patients, these subjects had, they complained of poor sleep quality, 70% or more. They had insomnia as their primary symptom in almost 50%. And this is, again, unlike the general medical population, where only about 25 to 30% have insomnia as the primary symptom. So we have a very different phenotype of population that has, sleep apnea in general. Next. And what we found was there was a 75% prevalence of sleep apnea in the responder population. Only about, and about half of them had mild OSA, and about a quarter had, 30% had moderate to severe OSA. Next slide, please. What was interesting is if you just look at the prevalence of sleep apnea in the general population versus the World Trade Center snore study that we did, looking at a European study, which is Hypna-Laus, and a US study, which is the Wisconsin cohort. If you look at men and women, you look at whether it's moderate or severe OSA, or you look at OSA with sleepiness, there was a clear higher prevalence of OSA in men and women in our study population compared to the World Trade Center, compared to the general European or the sleep Wisconsin cohort. Next slide, please. And what we found was that if you had chronic rhinosinusitis as a risk factor for sleep apnea, you had almost a 1.8-fold increased risk for OSA as compared to if you did not have CRS. And we use two definitions of chronic rhinosinusitis, one that has been used in the World Trade Center prior studies, and the other is a EPOS definition, which is a more epidemiological definition for non-World Trade Center responders for the presence of CRS. But in either situation, what we found was a 1.8-fold increased risk, even if you adjusted for age, sex, BMI, GERD, and regular alcohol use. Next slide, please. And again, like I said, presence of OSA was higher whether we use either definition. Next slide, please. What was interesting, though, is we then looked at awake nasal resistance in this population, in this study cohort, and we found no differences between those with and without OSA or with and without chronic rhinosinusitis. So that nasal resistance doesn't seem to play a role in the association between OSA and CRS or the presence or absence of OSA in this population. Ongoing studies are looking at what other mechanistic processes are involved in these World Trade Center responders developing OSA. Next slide, please. So I'm going to come back to the mechanism and how it is, that we can personalize treatments for OSA, not only in this population, but in the general population as such. Like we discussed, nasal congestion is a huge problem in this population because of presence of chronic rhinosinusitis that may affect the route of breathing. However, that can increase surface forces that can actually lead to sleep apnea. On the other hand, nasal congestion itself can lead to a smaller upper airway lumen. And then there are these other factors, genetic and ethnic factors, obesity plays a role, the gender plays a role, and as you age, that can also affect your predisposition to sleep apnea, and therefore can lead to these other non-anatomical reasons for developing sleep apnea. Ongoing studies are looking at other ways of treating sleep apnea other than the general use of CPAP. CPAP stabilizes the upper airway, splints it open, and is always effective. However, compliance remains a chronic, constant problem with the World Trade Center responder population, especially having a compliance in the 20 to 30% range. So we're looking into whether actually using things like benzodiazepines, sedatives, which seems counterintuitive to do in a population like this, would be helpful for the treatment of sleep apnea. The way it would work is to reduce that low arousal threshold and make the patient sleep more stable and therefore prevent those recurrent apneic events. The use of hypoglossal nerve stimulation is becoming more frequent now in the right population where you see poor upper airway muscle function. The use of oral appliance therapy, again, may play a very important role in this population, given the nasal congestion issues and certain features that they are not obese and have a small upper airway lumen. Next slide, please. I just wanted to give you a brief idea of what the oral appliance therapy recommendations have been for sleep apnea. It's basically for treatment of primary snoring. And for OSA, it is basically a custom titratable appliance is preferred over a non-custom oral device. So somebody going to a pharmacy and saying, I picked up an oral appliance, it's not a good idea. If you are, especially our responder population, many of them are intolerant of CPAP because of claustrophobia and other issues. That may be the way to go, oral appliance therapy. Clearly, you need a qualified dentist to provide this therapy and, to ensure that they are looking for dental-related side effects or occlusive changes so that they are following up with these patients. And following the making of this oral appliance, there needs to be sleep testing to confirm that it is actually working and efficacious in the management of sleep apnea. And finally, the subjects need to, or patients need to come back for periodic office visits. Next slide, please. Just a quick slide about CPAP intolerance. I know that that is a major problem and that many referrals to us come because of CPAP intolerance. I spend a lot of time motivating and educating patients on what sleep apnea is, what the consequences, the health consequences of sleep apnea are, and that pays off huge dividends in improved compliance in these patients. We always assess the nasal pathology given how significant that problem is in this population. I often am constantly using nasal decongestants or nasal steroids, referral to ENT for possible surgical procedures to improve nasal passage anatomy. And we always look to do mask fittings in our sleep, in our outpatient clinics to make sure that the patient finds and is able to tolerate the best mask that is out there. And we look to see if I can use sedating agents that will help them tolerate CPAP. So the use of sedation, not just as an alternative to CPAP, but as a supplement to CPAP to allow for CPAP compliance. And there are RCTs that show that this does work. And if there is, we almost always use AutoPAP as the primary way to treat these people because these people often have just positional or REM-related apneas, and therefore I consider the use of AutoPAP as standard in this population. And actually, that statement about expiratory pressure relief or bi-level pressure, although it was published in the Lancet, I do not agree with. In fact, we studied this in this population and found that patients actually prefer not to have expiratory pressure relief, and bi-level has no better than CPAP. And there's actually worry that bi-level may actually be more intolerant, patients may actually not tolerate bi-level so much. And finally, like I discussed, oral appliance therapy, upper airway surgery, or other forms of treatment. Next slide, please. I'll bring it back to Iris to talk about her easy and difficult cases. We have about 20 minutes. I hope that's sufficient time to go through the 3 cases. Thank you for your attention.
So this is the easy patient, so to speak, and Dr. Sunrum spent some time talking about the key being spending time with the patient and motivating the patient and treating what we can treat. Overwhelmingly, we see truck drivers, people that want to have a commercial driver's license, people that are truly afraid of having accidents and other health conditions. So those are the motivated people that are, how am I going to be able to drive my truck? These are the ones that the primary care can generally manage themselves. But notice we're treating their rhinosinusitis, giving them the nasal steroids. Notice that we're making sure their gastric reflux is treated. Moderate sleep apnea, not the severe cases. So these are the guys that come every year. I actually am qualified in doing the commercial driver's license. These are the ones that come to me with the compliance chips. Dr. Sundra mentioned a little bit about compliance, and I want to say it's like the diabetic that knows their hemoglobin A1C. That's the diabetic that's easy to treat. The sleep apnea patient that comes in with their compliance report that knows how to find it on their phone. This is the one that we hope all of you will be able to treat, factoring in your understanding of the comorbid conditions, treating them properly, and using the auto titrating machines. So this is one I feel comfortable with, and I hope you'll feel comfortable with, as compared to the next slide. This is a guy that has, this is a particular patient that I was thinking of that I spent a long time before I can even motivate him to see Dr. Sunrum. But not only his sleep apnea is very, 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 very severe, and his respiratory issues, his asthma is pretty severe also. Doing the best we can with the PPI and the H2 blocker, and doing the best we can with the sinuses. Spent a long time with this guy. He is sleeping better, but he's not driving the truck. And I am turning this over to my colleague because this is a very challenging patient here. So Dr. Sundram, you want to comment on this patient here?
Sure. I think, yes, this is an extremely difficult situation, especially because this patient is extremely symptomatic. Now, this is very interesting because in general, what we see is patients who are extremely sleepy, the one benefit we find from CPAP, well, the few benefits that we have documented with multiple studies have shown that sleepiness definitely improves, mood improves, and attention improves, and in general, the quality of life, the feeling of, that the quality of life has improved, has been shown in multiple RCTs with CPAP. So this patient should, improve with CPAP therapy. However, if they have been compliant, and when we mean compliant, we use the Medicare definitions or the insurance third-party coverage definitions of compliant, which is more than 4 hours and 70% of the time. So if you think about it, 5 days a week and using it 4 hours of the night that they're sleeping. Now, these people in general, like I said, sleep about 6 hours. So that's only about 60%, 2/3 of their time that they're using the machine. So realize that 1/3 of the time they may not be using the machine, and while they're asleep, have untreated sleep apnea, and realize again that with an event index of 100, these people are stopping to breathe every 30 seconds almost for a period of 10 seconds. And so in that period of time that they're not using CPAP, so let's say they have been supposedly compliant, but using it only 4 hours a night, but sleep for 6 hours, they're 2 hours of the night that they're not actually using the device. And that is resulting in multiple episodes of events that therefore will lead to the residual daytime sleepiness in this population.
And I want to say before we go to the next patient that this is a long-term patient that we both follow. So 2 things. One is that I can tell by his general crankiness whether or not he's using the CPAP. And the other thing is, and Dr. Sunrum's very modest about this, but one of the things our sleep clinic offers is, in addition to the physicians, we have our technician, who I hope is listening to this talk, Darius, giving you a shout out if you're there, making sure our patients have the right masks that really fit, because especially for a patient like this, we want to do everything we can. And our last slide, the next slide, is really challenging, and this is typical of many of our patients. Really bad claustrophobia, really bad post-traumatic anxiety, depression, really irritable, unable to tolerate the CPAP. He really doesn't like things in his mouth either. This is the patient that we're all struggling with right now. So what do you think?
Yeah, so this is the hardest patient to treat for their sleep apnea because, again, and this is something we are studying, is like I said, the phenotype that is very common in this population is this phenotype of disturbed sleep, having non-restorative sleep and poor sleep quality, but actually not very sleepy during the day. And so, and studies have shown that, if you put them on CPAP, they don't really see a big difference. In fact, their insomnia may get worse. And so that's why they come back to you saying, I don't like this mask, I want to take it off because I don't get good sleep continuity. However, they have very severe OSA with native sats hitting 70%. So they really need treatment for their OSA. And we have to think of alternate treatments to CPAP in this situation where you have this problem. So we start with oral appliance therapy. While oral appliance therapy isn't great for severe sleep apnea, because what we know is it does reduce the number of events by greater than 50%. But at least if you get compliance of use every night, you have some treatment effect from oral appliance therapy. Again, like Iris mentioned, treating the nose, making sure the nasal passages are open are really important in this population. But if both oral appliance therapy is not tolerated, CPAP is not tolerated, then this is the kind of patient who, we know these people have a BMI of less than 30, may be candidates for hypoglossal nerve stimulation. I know the program doesn't pay for it, but this is the kind of person who, unless we can help them, may be a candidate for hypoglossal nerve stimulation. Now, having said that, I think ongoing studies that we are doing looking at disturbed sleep and this phenotype of poor sleep quality and disturbed sleep, and looking at the endotype of, a low arousal threshold, and if there's an association, maybe actually, excuse me, actually the use of benzos in this situation, while it seems kind of radical with a saturation of 70%, There have been actually studies that show that they don't worsen sleep apnea and may actually be helpful. And so obviously that is a clinical trial that we will have to do, but this is the kind of patient that who would fit that kind of clinical trial population.
The other thing about a patient like this, though, is this is the patient that I beg to have the best psychiatrist see, because sometimes this type of patient is not really, I want to say maybe undertreated for their mental health disorder. And sometimes if we can improve the treatment of the mental health disorder, and if we have the psychiatrist working with the sleep people, we might be able to do a little bit more, but I'm saying might also, because this is the really frustrating one that we have, that we think we've thought of everything and the patient's not sleeping.
I totally agree with you, Iris. Here is a situation where, we know that even with PTSD, there are, association of PTSD with sleep apnea. It's not clear, whether it's a chicken or egg, but there is that association as well. And so simultaneous treatment of all these comorbid conditions, including anxiety, depression, the PTSD aspects, and treatment of, the sleep apnea are critical in this population. I don't think I have a good answer for you in terms of what's the best treatment in this patient, but working to try to figure out how we can personalize the treatment is the best approach.
So let me interrupt you guys. Yes. So this is Jeff Calvert again. Thank you so much for a very interesting presentation. And I want to tell the audience that the PDFs of the PowerPoints are in the chat. So hopefully you can see the chat and download those PowerPoints if you're interested. So the question that we received is, so in a person with mild OSA, how do you ensure and determine that the patient's sleepiness is due to OSA only and that other causes of the patient's sleepiness were ruled out?
It's never due to OSA only.
I agree with Iris. So mild OSA to cause very severe sleepiness is very unusual. And so you really have to look for other sleep disorders. This is the kind of patient who needs an overnight sleep study to confirm they don't have, for instance, periodic limb movements as a contributing factor that is disrupting their sleep at night. And I can tell you, and Iris will confirm this, that a lot of the responder population have restless legs and PLMs as a comorbid conditions, comorbid sleep disorder that we kind of treat simultaneously, because it does play a very significant contributing role in their poor sleep quality as well as daytime sleepiness. Now, if you don't find periodic limb movements, then you have to think of other primary sleep disorders that may be contributing to their sleepiness, such as narcolepsy. It's not unusual to find a patient who's been diagnosed with just mild OSA, who is extremely sleepy, who actually has something like narcolepsy as a problem. Now, just as a clarification, and somebody who has, on the other hand, moderate or severe sleep apnea, was very compliant with CPAP, and that was our, I think, a second case, who is persistently sleepy. We do have a situation oftentimes. I brought up the fact that maybe they're not compliant, but let's say you find the compliance data is very, very good, and they're using their CPAP all night, every night, despite which they are extremely sleepy. And this is, I'm talking about somebody who's had prior moderate or severe sleep apnea. Then there are unfortunately a subset of patients who have had sleep apnea for so long that for reasons that are not clear, their wake promoting neurons have been affected, and therefore they have persistent daytime sleepiness despite adequate treatment. This is a group of people who we do put on stimulants in addition to their CPAP therapy to help them stay awake and be alert.
I want to add on to that, and they may also be not sleeping well because of something other than a sleep disorder. So I want to make sure that if they have reflux, that they're taking their medications correctly and that they've had endoscopy to make sure there isn't something worse than reflux there. And I also want to think about their mental health and see if their mental health is in order and that we're doing what we can do for the mental health. So are there other questions? Or did we answer your question from the chat here?
I think you did, and we're actually running out of time. I think we're at have about 3 minutes left. So I'm going to now talk about the continuing education. So continuing education credits are available for physicians, nurses, pharmacists, public health professionals, physician assistants, and other professionals. To get those, you need to log in to the TCEO website. So if you don't have an account, you'll need to set up an account. And when you do that, you'll be coming up with two security questions. And every time you log in the future, you'll need to answer those same 2 security questions. So be sure to keep those simple. And then once you log in, you'll see this menu of items that I'm showing on the right. And I've got circled search courses. So that's what you'll do next. You'll click on search courses. And when you do that, you'll see the fields on the right. And what you'll need to do is where it says course number, you'll need to type in this number, the WC 4740, 12. This is today's date, 12/14/23. So, and then once you type that in, you should be an entry for this course, this webinar should pop up. The other alternative way to do it is look at the date and look at all of the webinars for December. And I think there's like 4 pages of webinars, about 5 webinars on each page. So you can quickly scroll through and find this one. And then what you'll do is once you've enrolled into this webinar, selected it, you'll need to complete an evaluation. And it's not obvious, the link for the evaluation, but look closely and you'll find the link for the evaluation. Complete the evaluation, and then once you've completed the evaluation, look for the link for the post-test, and then there'll be 4 questions for the post-test. If you answer 3 of the 4 correctly, you'll get your continuing education credits. And if you're a person, we're recording this webinar, and so if you're viewing the recording, what you'll do is you'll type in where it says course number, you'll type in the WD, not WC, the WD 4740 12/14/23. So if you're for the live course, the CE credits are only available for 1 month. So they'll be available till about January 15th. So don't delay. And then if you wait, once the recording gets posted on YouTube, probably sometime in early 2024, the CE credits for the recording will be available for at least 2 years. We'll likely renew those so that they'll be available for a total of 4 years. So we are pretty much right at the hour. Thank you very much for your excellent webinar, Drs. Udison and Sundaram. And with that, we will now sign off. Thank you.